Good afternoon to those of you who are with us already. We're going to get started in about 1 minute. All right, we'll go ahead and get started. Thanks for joining us, everyone, for the webinar on practical strategies for harm reduction with SUD patients. We're really excited about today's webinar and to have our speaker, Kim May, with us today. So I wanted to go over a few housekeeping items before we launch a quick poll and get into introducing our speaker. All of the lines will remain muted throughout the session to avoid background noise. The presentation is being recorded and it will be available for attendees upon request following the webinar. Throughout the webinar, if you have any questions, feel free to type those into the Q&A tab. You are able to make your name private if you'd like, so you can ask questions anonymously if you prefer. And then we'll address those questions at the end of the training. And then please be sure to complete the post-training evaluation as well. That'll pop up on your screen when you exit the webinar. And if you are requesting CME credits, then we do also ask that you complete a survey that will be placed in the chat by the end of the webinar. And the last housekeeping item that I wanted to mention is I'd just like to thank our funder, Maricopa County Department of Public Health, as well as CAHEC for providing continuing education credits to our participants. And then I'm going to do a quick poll to gauge your knowledge on this particular topic. Thank you, everyone, for typing your answers in. Give it another few seconds so that all of you can answer. Still got some votes coming in. All right. So here are the results, just so that you all can see them, where our knowledge gauging is at right now. It looks like we do have some people that feel pretty knowledgeable on harm reduction, so that's awesome. Some not too sure, more in the neutral section, and then quite a few people that feel somewhat knowledgeable. Thanks everyone for completing that. So now I'm going to introduce our speaker. Her name is Kimberly May, and I'm very grateful that she agreed to come and speak with you all today. I think that you're going to really enjoy her and what she has to share with you all. She's the founder of Substance Use Therapy in Austin, Texas, and specializes in serving individuals, couples, families whose lives have been affected by substance use. She works with a harm reduction model to support people wherever they are on their continuum of use. So with that being said, I'm going to hand it over to Kim so that she can go ahead and get started.
Oh, now it's the navigating technology. All right. I'm going to share the screen. go into presentation mode. Almost there. Whew, okay, that's the hardest part of this whole thing. Awesome.
Good
Hello.
job, Kim. Thank you.
Thank you. Thank you. It's always the most stressful part of these for me. So I'm so happy to be here talking to all of you. I'm grateful for the opportunity, not just to present, but specifically to present on harm reduction, because it is such a tremendously important topic. And unfortunately, it's becoming increasingly relevant, increasingly crucial. 2020 saw the highest number of overdose deaths ever recorded in a 12-month period. Approximately 93,000 people lost their lives in 2020. It breaks down to about 254 people a day. If you're anything like me, you have trouble sometimes conceptualizing large numbers. So 93,000 is the approximate population size of Santa Monica, California. I did some Arizona research. According to the Arizona Department of Health Services, in 2020, there were 1,886 confirmed opioid-related deaths in Arizona. So that's not even total overdose, that's just related to opioids. That's a 45% increase from 2019. I wanted to go back a few years and try to understand the trend better. From 2017 to 2020, Arizona saw a 104% increase in opioid-related deaths. So harm reduction becomes increasingly relevant in times like this, because harm reduction is really about saving people's lives. So what is harm reduction? Harm reduction originated in the 1980s in Europe as a response to the HIV crisis. Essentially, harm reduction is just a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. What also kind of sets it apart is it's also a movement for social justice, built on a belief in and a respect for the rights of people who use drugs. So many people in the harm reduction movement are people who are currently using or have used, and they are really the voice of the movement. Despite many aspects of harm reduction being evidence-based, there is still a lot of stigma around it. And to a certain degree, I kind of get it. You know, there's some aspects of harm reduction that can make us feel, I don't know, feel a little squishy. Some of it's kind of but what a lot of people don't realize is how many examples of harm reduction we all live with every day. Probably one of the ones we're most familiar with is designated drivers. You know, the designated driving campaign never assumed that people weren't going to drink, didn't even really tell you to drink less. You know, the implication was you do you, but then have someone drive you home after. The target is not on the act of drinking, it's on the act of driving after drinking. Another great harm reduction example is nicotine replacement therapy. For individuals who have nicotine addiction, it's the delivery mechanism that is so harmful, right? The chew, the cigarettes. Nicotine replacement therapy is a way to give people the drug, the nicotine, just in a much safer delivery system through gums or lozenges or patches. And one that kind of I'm partial to. It's a website now, but back in the day, it was a book series called Eat This, Not That. And they were these kind of big, thick, glossy, fun books with like tons of pictures of food in them. What made this book series really different was it didn't tell you this really perfect, ideal way to eat like so many books on diet and nutrition do, right? Eat this, not that understood that despite our best intentions, we're going to end up in the drive-through lane. We're going to end up at the Cheesecake Factory with one of those book-sized menus. And when we do, there are better choices that we can make. We don't have to make a perfect choice to make a better choice. So naturally, we should talk about meat. I am in Texas. So some years back, my dad was in the hospital for a heart thing. He's fine. It's not a sad story. And as he was getting ready for discharge, a doctor came in. He was like, "Sir, we should talk about meat." I have no idea if my dad and this doctor had had a previous conversation, or if this doctor just understood something about a certain sort of Texas man. Regardless, he knew meat was a conversation they needed to have. And what he told my dad was this: when it comes to meat, you can have meat that comes from animals with 4 legs, rarely. You can have meat that comes from animals with 2 legs, sometimes. And meat that comes from animals with no legs, as often as you want. It's short, it's easy to remember, it's sort of funny, and really important, it doesn't have the word no, and it doesn't have the word never, which for someone like my dad is really important. I know that you don't know him, but he has a 7-foot barbecue pit in his backyard. So suffice it to say, meat's a big deal. What that doctor did was give my dad a framework that he could use to make improvements that respected what was still important to him. Is my dad's diet perfect? It is not, but it's substantially better. And a lot of that I attribute to that approach that that doctor took. So we've kind of got this overview framework of harm reduction. So what does it start to look like when we're applying it to a more clinical setting? The first, and perhaps one of the most important components, is we meet people where they are. So, you can conceptualize this as sort of on that stage of change model, right? Some people are finding us when they were at that action stage. Some people are still way back at pre-contemplation. In harm reduction, it's fine. Wherever you are, we're here for you. And then we first reduce harm caused to themselves or others through the substance use. So rather than targeting the use, we're minimizing the harm. And then we feel like it's really crucial to get to know each person and their relationship with drugs and alcohol. And that word relationship is intentional because it highlights the emotional connection that people tend to have with their substances. And then we see each person as an individual who may have complex needs that extend just beyond the substance use. At its heart, harm reduction is about compassion. It's about pragmatism. It's about collaboration. Much of it is also very tangible, and it fills a much needed gap. For those of us who work regularly in substance use, we're probably used to a lot of those, like the big flashy billboard themes, right? That people come in with: depression, anxiety, trauma. But alongside that, beneath that, are these themes that emerge over and over and over. And left unaddressed, making improvements regarding substance use, or really kind of a lot of life changes, become very difficult. One of the key ones is unhealthy or non-existent boundaries. When I think of boundaries, I think of the way that they build skyscrapers. Modern day skyscrapers are designed to sway in the wind, right? If they were too rigid, they would snap under windy conditions. And if there's too much movement, well, you don't have a building anymore anyway, so it doesn't really matter. How much they need to sway depends on the building, depends on the geographic wind conditions and all of that. Ideally, Our boundaries function in much the same way. Strong enough to withstand difficult conditions, but with enough flexibility to adapt to changing circumstances. Boundaries are so key because they inform our sense of identity and they help us feel safe, secure, respected, and differentiated from other people. Another one that comes up over and over is shame. And when we are in a shame state, we are essentially feeling unworthy of connection. Being in a shame state is a great way to induce wanting to use. Feeling shame is a terrible feeling. Many of us are pretty motivated to make that feeling go away by any means necessary. And it's unfortunate, but even now, 2022, there's still so much stigma around substance use. And that stigma contributes to that shame, and that shame, frankly, just makes us want to get really high. We help people navigate this by trying to help them understand their problems rather than condemning their problems. And a great way to help do this is by taking the stance of objective curiosity. Being curious, trying to understand that relationship with substances, but without judgment. And another big one is a lack of self-compassion. I've had client after client after client just honestly identify saying, I feel like a piece of shit. I hear it all the time. In fact, I heard it so much that I started spending some time kind of trying to really understand what self-compassion was and researching it. There's a great researcher, her name is Kristin Neff, and she specializes in self-compassion. And on her website, she has a test that people can do to kind of test their level of self-compassion. And I've included the link on there. What I like about this test is not only does it just give you kind of an overall score for self-compassion, it gives you scores in several different domains, like self-kindness, self-judgment, isolation, common humanity, right? These different components that all together kind of comprise our level of self-compassion. I very frequently will refer clients to taking the test and then invite them to bring the results back in, and then we can kind of talk through it. Like many of you, I'm sure I oftentimes work with parents or partners or spouses of people with substance use issues. For simplicity's sake, I just call them caregivers. And for so long, the primary guidance that caregivers have been given is this tough love model, tough love, tough love. Well, for most people, most of the time, tough love isn't terribly effective because it relies on strategies like control and punishment. If punishment worked to cure substance use, we would have tackled that quite a long time ago because we've been pretty punitive about it. So when I work with caregivers, I oftentimes try to help them move away from this kind of punitive control space and work towards adapting better boundaries. Boundaries for caregivers are so important because boundaries are about what we need, not what we think is going to change someone else. And it's such a key distinction. I also work with caregivers to rethink concepts like enabling and codependency. I think we have to be so careful before we use labels like that. If you call me 3 times this week to come pick you up because you're too drunk to drive home, and I do it, am I enabling you, or am I giving you life support by making sure that you don't hurt yourself or somebody else on the road? In one of her books, Pat Denning gives this example of a young wife, young children they have, married to a man with alcohol use disorder. And pretty frequently, she is calling her husband's boss and making excuses about why he is going to be late or why he's not going to be able to make it into work. And she's struggling and she goes to see a counselor, and the counselor's like, You are part of the problem. That's codependent, enabling behavior. The lady's like, oh gosh, I don't want to do that. So she stops. Pretty quickly, this plunges the family into poverty. The husband has difficulty obtaining a new job, which worsens his mood, which worsens his drinking. When we are considering what constitutes enabling or codependency, we oftentimes have to look at it from a systemic perspective, right? Because calling the boss wasn't just about supporting the husband, it was about supporting the entire family. We also have to be mindful that there are huge cultural differences. What may be enabling or codependent in one culture may be completely reasonable and expected in another culture. Also with caregivers, we have to consider what role they're taking on. This is something I work with a lot, is helping caregivers get out of that role of being the manager of the use or the gatekeeper of the use. Again, it's kind of about control, and it tends to cause resentment on both sides. Avoiding seeking out promises, I think, is a really big one. So often caregivers, they want to promise, right? That this time is going to be different. This isn't going to happen again. And it's a natural inclination, but I really discourage caregivers from seeking out promises related to substance use. Because as we all know, substance use, even for people who are really, really trying and they really, really want, abstinence, sobriety, it's not always like this perfect linear trajectory towards improvement, right? There can be setbacks. And when there are, and that violates a promise, it feels personal. It feels like it's about the relationship, and substance use typically isn't. And then this kind of goes back to the boundary thing, but helping caregivers determine what they can realistically take on and knowing when it's too much, whether that's logistically, financially, emotionally, because we don't want to cut people off or change our level of support for punitive reasons, but caregivers do have a right to have boundaries and practice self-care. As we're going through this and we're talking about substance use, and I'm saying the word substance use over and over so many times you'll get sick of me saying it, I'm not talking about substance use from this binary perspective, right? So often we think about substance use, it's someone is using or someone is not. And really, substance use is so much more complex than that, right? There's all different kinds of ways to engage in substance use. We're pretty flexible about that in our society when it comes to alcohol, right? There's all kinds of ways. Being a habitual drinker is not really viewed negatively, right? Oh, I drink every weekend. I go to happy hour every Thursday. When it comes to illicit substance use, we tend not to be so flexible. And in harm reduction, not all illicit substance use is considered abuse. So if you notice on the continuum, the arrows go both ways, because just because someone is using does not mean that their use is going to necessarily worsen. And many people's use does get better without any formal treatment. And it's something I think we forget, because in our profession, those aren't the people that we tend to come across very often, but it is true. I like to keep a version of this in my office and actually show it to clients and ask them, where do you see your use? Beyond that, where do you want your use to be? Because I don't assume that everyone that comes to see me has abstinence as their goal. And sometimes people will get really specific. They'll be like, I'm a 3.9. I would like to be a 2.2. Like, okay, specificity is helpful. The thing is, if we treat people only as if they were at the ends of the continuum, then we're neglecting a whole host of experiences and feelings and complexities that may be happening in the middle. And if somebody comes in at, 4 or 5 abuse or dependence, and they move back to habitual or social use, they may not be at abstinence, but they may be in a better and safer place. And I did want to kind of drive this point home. Progression from use to dependence is not inevitable. It's not even the most likely outcome, but it does happen. And when it does, when it does progress in an unfavorable direction and it does constitute addiction, we see it as a biopsychosocial phenomenon, right? The full picture of how and why a particular person becomes addicted to a particular substance is incredibly complex. So it's important to kind of start pulling out that biopsychosocial information. But it's so important that we don't use their history and that information as a deficit-based view of a person. Because right from the get-go, we have to be looking for strengths, because our strengths are also a biopsychosocial phenomenon. And our strengths are what are going to help us make any positive changes in our life. Also, for some people, substance use may be temporarily problematic due to biopsychosocial stressors or crises. And when that's the case, supportive counseling around the underlying issue may be enough to return the person back to non-problematic use. So let's look at a non-substance use example. So let's say you are working with someone who's been going through some really intense, complicated grief. And in dealing with their grief, they have turned to food. They have some, relatively unhealthy eating patterns. They put on a lot of weight. We wouldn't necessarily look at that situation through the lens of this person has disordered eating and it's going to lead towards, obesity and heart disease and ultimate death, right? We would see this is a person struggling. This is a person in pain. This is a person grieving. And this person needs support. This person needs additional coping strategies and appropriate ways, more adaptive ways to process that grief. And knowing then that the issue with the food may then subside. And it can be similar with substance use sometimes. So as we're working with the client, we are helping them to establish their goal. For those of you that went to any sort of school for therapy or counseling, you were probably taught to ask the question to the client, what would you like to see change? Such a basic question that we so often forget to ask of our substance use clients because we think we know it needs to change. We're like, you need to stop shooting meth every day. How about that? Let's make that your change, right? But there's so much more value when we ask the client what their goal is, and we accept and embrace that they may have some ambivalence about their goal. Ambivalence is usually the sign of a healthy and functioning brain that's capable of seeing like gray areas around issues that are very complex. And our role as clinicians is not just to simplify someone's ambivalence by only addressing one side of it, but rather to help them explore both the harms and the benefits of their use. I think most of us identify with these feelings of ambivalence, right? Maybe we eat too much. Maybe we're in not so great of a relationship. Maybe we're in a job that makes us unhappy. There's always a reason to stay. There's always a reason to go. There's always a reason to change. There's always reasons not to. And we usually need time and ideally support to make decisions and then make plans around those decisions. And it can be the same with our substance use clients. And as we're helping identify their goal, we are kind of working on this needs hierarchy, right? And again, ideally from a client perspective. So a client may be suffering from substance use issues, and they also may not have a place to live, and they may also have court issues coming up, right? Ideally, we let the client participate, if not determine, where they start. If I'm working with a client and they choose to address a work issue rather than, say, a rampant cocaine issue, it's fine. We can start there. We'll start with work. Now, I may start looking for connections between the cocaine use and the work problems, but how and when I bring those up with the client may be determined by trust and rapport and their own readiness for that kind of feedback. When we meet clients where they are, oftentimes the resistance goes down. My role is not to tell them what to do and how to do it, but to give them support and guidance and expertise that helps them determine their own priorities. When someone contacts me to initiate services, I offer everybody a free 30-minute consultation, just so they can meet me and ask questions, make sure the fit is right. And I was doing a consultation with someone. He had initially contacted me primarily because he had concerns about his drinking, but he brought up a whole lot of other things, work things and relationship and some family trauma. And so near the end of the session, I clarified, specifically what is it that you're wanting to address in our work together. And he thanked me for asking. And he said, I like that you asked that, because I don't want to just be seen as an alcoholic. Like, I'm more than that, and my life is more complicated than that. Humorously, he also didn't have an answer to my question. That's okay, he can take his time. And he did come up with an answer, and we've been working together for about 1.5 years now. So it's going well. Velociraptor. So people from cultures around the world have been using drugs for thousands of years. Why? Because drugs work. They just do. You want to minimize physical pain, minimize emotional pain. You want to stay up all night. You want to have better sex. You want to feel more like yourself, feel less like yourself. There's a cure for what ails you, right? Now, we know that very often the drugs end up causing substantially more problems than they solve. But for many people, the initial motivation to use is self-care, not self-destruction. When people come to us kind of addled with guilt and shame about their choices, sometimes just connecting back to this simple idea that your choice to use drugs might have made sense for you back then. You had undiagnosed bipolar disorder. That must have been really scary and overwhelming. I get why drugs seemed like a good choice for you. Given the neglect and the trauma that you endured, it makes sense why you needed an escape from that. Given that everyone that you knew, from your peers to your family, was using, it makes sense that you were part of that culture and that you started using, right? It's not about necessarily condoning the use, but validating the place that someone is in sometimes when they make that choice to use. And understanding that and validating that can be a really key component of starting to minimize that shame for people. For such a long time, we really relied on these studies that people did with rats, right? Where they put a rat in a cage, usually in isolation, and they give it lots of access to drugs. And then the rat does all these drugs and becomes addicted and dies. It's not a happy time for rats. There was another researcher who was like, well, let's try a different kind of study with these rats. And he created Rat Park, which was essentially a haven for rats, right? There's tunnels and wood shavings, food and water is plentiful. There's other rats to hang out with and have sex with. And also there's drugs there. What they found was that the rats in Rat Park consumed significantly less drugs than any of the rats in isolation did. Very few of them became addicted and virtually none of them overdosed. They were like, okay, interesting. Well, let's take one of these isolation rats and move them into Rat Park and see what happens. What they found was that over time, those rats used less drugs. In his work, Bruce Alexander has said that maybe addiction is not a disease. Maybe it's an adaptation to our circumstances, to our life, to things when they seem bleak. When we're working with people and their use seems chaotic and painful and seems like it defies logic and intervention, we sometimes have to consider that maybe people are living in cages that we just can't see. People who are actively using can and do participate in treatment. I swear it's true, especially when they're granted the freedom to address their issues from their perspective of importance. Now, this isn't to say that every single person who's actively using is completely appropriate for any given treatment at any given time. Certainly not. But my point is that actively using should not preclude people from participating in treatment. Very often, it's the interactions between the clinician and the therapist that create an environment in which change becomes possible. When we say things like, tell me how you see your problems, when we avoid confrontation and these quick fix solutions, we help foster that environment. Terms like denial and lack of motivation are not always accurate, and they're very rarely helpful. It is completely natural to hide things when we think that we're going to be judged or pushed or punished. Increasing motivation for change is the work. That is our work. It's not a condition for beginning the work. I don't expect any client that comes to see me to have already done that difficult kind of soul-searching work of figuring out exactly what needs to change and how to change it, and then have started that change, committed to that change before they work with me. Each time I'm prepared to navigate that alongside them. And that's also kind of a hallmark of harm reduction. In harm reduction, we believe that any step in the right direction, or any change is a step in the right direction, any reduction in harm. For years, I worked at a methadone clinic, which I loved, by the way. They told me it was going to be doing like therapy on a pirate ship, and I was like, I'm in. So a not uncommon scenario at the methadone clinic was someone would present for intake and they'd be using, say, a gram a day, gram of IV heroin every day. And they're kind of in rough shape. Things aren't going that well for them. Flash forward a little bit, they're getting stabilized on their dose. They're starting to feel better. And they come in and they say, I'm down to a 1/4 gram a day of IV heroin. In that moment, I have a choice. I can choose to focus on the fact that they are enrolled in treatment and they're continuing to use, and I can make that the point. Or I can focus on what that reduction from a gram to a 1/4 gram of heroin represents. It represents fewer needles, less risk of overdose, less illegal transactions, less financial resources being diverted away. And when I choose to focus on their progress, they tend to feel more motivated. They tend to feel better about themselves. And when we feel better about ourselves, we tend to make better choices. So much about harm reduction is about people figuring out what are the right shifts and the right changes for them. If I go to my doctor for a physical and he looks at the results and he's like, you're not getting enough exercise, he's not going to prescribe me tennis. And if he does, I'm not going to do it. It's just not. I'm wildly uncoordinated. I'm not going to do it. But fortunately, that doctor is not going to say you need to go play tennis. That doctor is going to say you need to get exercise. And then it's up to me to figure out, based on my schedule, based on my logistics, based on my, financial constraints, based on my, age and abilities and previous injuries and all of that, what exercise is right for me. There's no one good, right exercise. It's about what exercise is right for us at a particular time in our life. And ideally, treatment functions in much the same way. But for any treatment to work, people have to feel like they can do it. Our sense of power, control, confidence, these things are critical to make changes to our life. So much of our work is about trying to empower people. And very often, people have done really awesome, amazing things and had successes that they just don't see or that they just don't realize. I was working with a woman. She was seeing me for issues related to alcohol, and her drinking was definitely problematic, nothing tremendously terrible, but it was unhealthy. And she mentioned one day that had she not had her child, she knew that her drinking would be substantially worse. And she said that she'd probably have a cocaine problem as well. And she said, my baby saved my life. I was like, well, you saved her life. She was adamant, no, my baby saved my life. Okay, well, I think your baby was the motivation, right? Your inspiration, but you saved your life. She was like, nope, it was my baby. Admittedly, I am no baby expert, but I've never known a helpful one, right? Never known a baby to pitch in. They tend to have a lot of needs and cry, and they're expensive, and they do all sorts of things at strange hours of the day, and people don't get enough sleep. And I said, I'm given to understand that having a baby is actually pretty stressful. So not only did you make the changes that you made them at a time in your life that was stressful and you were particularly vulnerable. And it took 15 or 20 minutes going back and forth before she was able to internalize that she had done that. She had always given that credit away and never credited herself with making these really positive and difficult changes earlier in her life. So again, so much of our work is about empowering people and helping them tap into that feeling of self-efficacy. Sometimes it's just about pulling out the really awesome, cool shit they've already done. Most people have done something that's worth honoring and recognizing. So we're doing all of this great work, right? We're helping people, we're empowering people. And what do we get for it? Very often, hopelessness and burnout. Doesn't seem right. Obviously, self-care is tremendously important. But sometimes we look at self-care through kind of a narrow lens, right? We look at it through that whole, engage in your hobbies, good work-life balance, the things that are tremendously important, don't get me wrong. But sometimes the way that we conceptualize our own work matters a lot when it comes to self-care. One of the first ways we can take care of ourselves is when we're able, redefine and reframe success. Because if only abstinence is success, then by extension, any use is failure. And that can be really stressful for our clients, and it's stressful for us too. I also build trust through a lack of bias. I just assume I'm being told the truth. I don't look for the lie. I just don't. If I find out later that I have been lied to, I choose to see it as a protective device rather than a manipulation. A caveat to this is anything that could be a potentially life-threatening situation, like someone's clearly too intoxicated to drive and they're like, no, I'm not. That's different. But day-to-day interactions, I just assume I'm being told the truth. And if they have lied to me, I don't take it personally. That lie doesn't have anything to do with me. It has nothing to do with me. I also try to create an atmosphere of understanding. And one of the ways of doing this is eliminating judgment, eliminating any judgment about their choices and their lifestyle. And when I do that, it improves the experience for both of us. And I think probably for me anyway, the most important thing is to focus on the process and let go of the outcome. Because no matter what, sometimes there's just not going to be a good outcome. And the question is, did you do the best that you could? Did you do everything within your scope of practice to help this person, to support this person? Did you get consultation if you needed it? Did you give them resources? Did you give them referrals? Did you show up within your scope of practice in every way you could for this person? And if you did, then you have to let go of the outcome, because the truth is we never had any control over it anyway. When I started working at the methadone clinic, I loved it immediately, but there were some things that caught me off guard, namely how often I was going to be yelled at and cussed at. And when it started happening, I was like, what is this? Like, what is happening? Why are you doing this? I came out of grad school and they talked about things like transference, but they didn't tell me what to do when somebody's screaming at me, telling me to go F myself. Like, that was not a chapter in any of my textbooks. And I was like, I don't know where to put this. And over time, it occurred to me that very often I was seeing people on the worst day of their life. I was seeing people the day after someone they cared about had overdosed, or right after their children had been taken from them by CPS, when they got fired from their job and didn't have money to pay for methadone treatment anymore, after finding out they had been diagnosed with Hep C or HIV. And I wasn't having the worst day of my life. Don't get me wrong, I had some bad days. Many of them were work related. But I wasn't having those kinds of bad days, and I wasn't having the worst day of my life. Seeing their struggle and their sometimes reaction within that framework really helped me tap into my own reserves of patience and compassion and understanding. For again, it wasn't necessarily that I condoned that behavior, but it gave me a way to understand it. At some point, I stopped working at the methadone clinic, and a few months later, I was driving and I did something that pissed off somebody while we were driving, and they rolled down their window and they, cussed at me really loudly at a traffic light. And I got like this flutter of missing the methadone clinic. I realized that I hadn't been yelled at in so long, it made me miss the clinic. So for better or worse, we are adaptable as humans. All right, gonna kind of switch gears. All right, talking about drug set and setting. This may be already familiar to many of you, but it was developed by Norman Zinberg. And he came upon this as kind of a counter to that tendency that we had to assume that it's the drug itself that has the greatest impact on creating addiction. And in reality, set and setting often determine the effects that we get from a drug. And it's those three interrelated factors of drug, set, and setting that combine to create unique experiences for people. It's why some people can drink tequila and have a lovely evening. And other people drink tequila and they start ripping toilet paper dispensers off bathroom stalls, right? Individual differences. So drug, set, and setting is something that you could do as its own kind of standalone assessment. You could incorporate it into an existing assessment. You can just work it in as part of a conversation with people. Very flexible in that way. So starting with drug obviously refers to potency, right? It's not enough to know that someone has issues with opioids because there's a huge difference between Vicodin and fentanyl, right? So what's the potency of the drug that they're doing? What's the route of administration? We're going to get very different effects from methamphetamines if we swallow it versus snort it versus smoke it versus shoot it, right? What kinds of adulterants are added? Knowing common adulterants to different drugs is really key for safety, especially nowadays with fentanyl. And this is a regional thing too, because, you know, drugs get sourced from different places. There are oftentimes regional outbreaks of certain adulterants. And so being knowledgeable of that sort of thing is helpful. How do the drugs work? Once they get into your body, what are they doing in there? I read in a book, I can never remember the book, but they referred to morphine as a chemical scalpel because it's so precise in how it works. And then it referred to alcohol as a chemical hand grenade because alcohol is like, anyway. And of course, how much someone is doing. And then we move to set. Set is you. These are your personality traits. Are you shy? Are you someone who likes a challenge? Are you, kind of the life of the party? Like, what are you like? What's your mood when using? And for people who use multiple substances, it can be helpful to go through these questions for each substance because, maybe somebody uses alcohol kind of whenever, all the time, but they only use meth on special occasions when they're feeling celebratory. What's your motivation? Why do you want to get high? What's motivating you to do that? What kinds of emotional issues is someone going through? Things like grief, divorce, family drama, moving, right? Like, what are the current emotional issues that someone's dealing with? And what are their coping deficits? How do they deal with difficult things? And health, mental health and physical health. And I skipped expectation. This one I think can be really telling. What are you expecting to happen? So there was a fellow, he's like mid-20s, mid to late 20s, issues with social anxiety, and he wants to date, right? But he has intense social anxiety. So he drinks before the date, kind of loosen up, get some of that liquid courage going. And then he gets to the bar, gets to the restaurant, sees her, gets all nervous again. So he has another drink or two. Before he knows it, he's like 5 or 6 drinks deep and the date's not going terribly well. His expectation is that the alcohol is going to loosen him up and make him more charming and talkative. The reality is he's just creeping out women because he's getting too drunk on the first date, right? So this is one of those times where the expectation is really in misalignment with the outcome. For some people, what they expect to happen does happen, but either way, it can provide some good insight into somebody's relationship with their substance. And then finally, we have setting. What's the environment? Are they in a park? Are they in a parking lot? Are they in a living room? Are they in a hotel? What's the environment? Are they alone or are they with other people? And who are those people? Is it friends? Is it random party people? How at ease or how rushed do you feel? There's a difference between, setting out everything you need at home to get high and taking your time and trying to get your works together and get ready to shoot up in a bathroom stall during a 5-minute break at work. It's the culture. Is their use frowned on by their culture? Is it a part of their culture? Do they belong to a particular subculture, which that use becomes relevant? In my experience, most clients enjoy this process because it's non-judgmental, and oftentimes it's looking at their use in ways they haven't considered before. I need to address a myth. There's a myth that harm reduction is against abstinence. It's not true. It doesn't make any sense. We don't get kickbacks from drug dealers or alcohol lobbyists if people keep using, right? The truth is, regardless of what any of us say or any of us do, there will be people who continue to use both licit and illicit substances in a way that's harmful to them. We don't condone use, but we respect choice. And at the forefront are always these really honest discussions about risk. Another tool I like, the decisional balance exercise. Super simple. Pros and cons of changing drinking and drug use, pros and cons of continuing the way that I am now. Seeing what comes out. Clients often work well when tension is maintained between what they like about their substances and the negative consequences they suffer as a result. It's very helpful usually for clients to keep exploring that relationship. And we can help support that by modeling curiosity, resisting premature conclusions. So as I'm going through one of these with clients, I'm usually looking for a couple of things. I'm looking for things that we can start to make improvements on, right? So we see sleep on here. I might start to have questions about their sleep hygiene patterns, things like that. I would see bars is on here twice. And I would want to know the significance of the bar. Is that their only opportunity for social connection? Do they live in a place where there's not a lot of other viable options for entertainment? Does someone in their family own a bar? And that's where a lot of family gatherings take place. Do they work in a place where it's very common after work where everybody goes, and it would actually not be so great for the career if they didn't go, right? What is the significance? Another one that I see on here that I would spend some time with is the idea of the fear of the unknown. And I think this is something that we cannot underestimate for people, especially when they started using young or for people who have been using for a very long time. They don't know what their life is like without it. And that's a terrifying thing. That's a terrifying thing to face. I was doing this exercise with someone once. He's a man around 50. He'd been drinking really heavily for like 25 years. And he said, I'm afraid my life is going to blow up if I stop drinking. That's huge. That's scary. That's overwhelming. So, we have to be willing to delve into these things. And we can't get too uncomfortable when people talk about the benefits of their use. Another thing to consider is that harm reduction does not try to remove a person's primary coping mechanism until others are put in place. So a tool like this can be helpful in seeing the different reasons that people are so connected to their substance from that emotional space, because that can help identify other coping strategies and other areas for improvement. We don't have to wait for people to completely change their use before we start helping them make positive changes in their life. So no matter how much great clinical work we're doing, we are always very much connected to helping people stay safe, helping reduce harm. So we'll look at some harm reduction strategies specific to both opioids and meth. For opioids, of course, medication-assisted treatment or medication-assisted recovery is certainly an option. Both methadone and buprenorphine are considered evidence-based approaches. People oftentimes have some pretty intense opinions about methadone and buprenorphine. I do not, because I do not have a license to have that strong of an opinion about medication. I do not have a license to practice medicine, and so I don't. I always make sure people know what their options are, and I connect them to resources and referrals so that they and their prescriber can decide what makes the most sense for them. Needle exchange. Oh my God, this is so important. So one of the great things about harm reduction is when it's really implemented well. Harm reduction supports and benefits individuals, but it also supports and benefits the entire community. Our entire community is better and safer when we have good needle exchange programs in place. For the record, I live in a state where it's not actually legal. Yay, Texas. Safe shoot practices. Always making sure that our clients have access to this really comprehensive information on safe shoot practices. A lot of it's about the needle, but it's also about the cooker and the water and the cottons and all of the components that go into safe shoot practices. It's not just about potentially spreading disease, it's about blood infections and endocarditis and all of these really scary, terrible things that can happen when people aren't practicing safe shoot. So we may not agree with the idea of intravenous drugs, but if they're going to do them, let's help make it as safe as possible. Fentanyl testing strips. These have become hugely important. People can actually test their drug supply, right? Certainly, there are people who intentionally seek out fentanyl, but more and more often, fentanyl is being surreptitiously added to drugs where no one's expecting any opioids, right? If I go buy benzos off the street, I'm not expecting there to be fentanyl in it. So people can get fentanyl testing strips to test their supply. Narcan, my spiel on Narcan is, it's like a first aid kit or jumper cables, right? Everyone should have jumper cables. Everyone should have Band-Aids. Everyone should have Narcan. I have a box of it on my bookshelf. It is always with me. I keep one in my bag because you never know. It's like literally a rewind button. It's amazing. With opioids, especially, using less after periods of abstinence. Counterintuitively, so much of what keeps people alive who are addicted to opioids is their high tolerance to opioids. Once they've had a period of abstinence, they have lost that tolerance and they're vulnerable. And sometimes we become so fixated on this idea of continued sobriety that we don't plan well for what happens if they slip. People coming out of jail, coming out of the hospital, coming out of treatment are very vulnerable. Also, using less in strange environments. Opioids in particular can be very set and setting dependent. People are more likely to overdose when they're in unfamiliar places. And so I always make my clients aware of that and talk about what kind of precautions they could take. Meth. One of the most important things people can do with meth to keep safe is avoid dosing on the high, right? Let themselves start to come down a little bit. Not everyone will be willing, but everyone deserves the information. We can't underestimate the importance of things like how to take care of their skin, access to first aid kits. Same thing with keeping their mouth moist and drinking plenty of water. It sends a very powerful and compassionate message to our clients when they are, say, very problematic. They're using meth, things are kind of a mess. And we take the time to talk to them about their skin and their mouth and how to take better care of their skin and their mouth. It sends a message that says, even though you're living this life and you're making these choices, you as a human being matter. And I want to find ways to help you be okay, even while you're not okay. Just like with opioids, fentanyl testing strips can be used. Avoiding sharing supplies. And, we think about that a lot with needles, but with things to snort, with things to smoke, we want to avoid sharing all sorts of supplies. Encouraging people to stagger their use, especially if they have a new batch or they bought from a new supplier, right? Let's not everybody get off at the same time, right? Let's have someone go and then other people be available to provide medical attention if needed. Regardless of how people use meth, they may be shooting it, smoking it, snorting it, ingesting it, plugging it, hot railing, whatever the method of choice, there is a way for that choice to be made a little bit safer. And so being willing to share that information with people, and also encouraging people to rotate methods. If you're working with someone who routinely smokes meth and they have asthma and they have COVID-19, would you be willing to switch methods for a little while? I hear you that you're not in a place where you're willing to stop doing meth, but would you be willing to swallow it or snort it instead of smoking it right now because I'm worried about your lungs? And then helping people know the signs and symptoms of overamp and overdose, how to recognize them in themselves, and also how to recognize them in other people. Because generally people want to help keep each other safe, and they oftentimes will if they have the tools to do so. I know that some of these methods and suggestions may not sit completely right with everyone. And again, I get it, some of these feel a little strange. The way that I reconcile that with myself when I stumble into that is reminding myself that dead people don't get better. Once they die, there is no second chance. There is no new day. Sometimes the best we can do is to keep people alive now so that later they have a chance to be well. As we come near the end, I want to leave you with my favorite quote. The opposite of addiction is not sobriety, it's connection. I like this quote because it reminds me that part of my role is not just to remove bad from someone's life, but to help them build up a life where they have meaning and they have connection and they feel better about themselves and about their place in the world. Very often, when we accept people where they are, as they are, that's when they feel safe enough to begin to change. I want to go over some resources. These are all for naloxone. At the top is a National Naloxone Finder. This is such a great tool, especially if you have clients that live, further away, or you have colleagues or people in other states. This is a great tool where you can enter in your location for anywhere in the country, and it's going to show where people can get naloxone nearest to them. The next is a really great resource for opioid overdose aftercare. If someone is fortunate enough to be in a position to save someone's life with Narcan, this kind of walks people through the aftercare. What should you do next? Because a lot of times it doesn't just end with, a couple of sprays of Narcan and everyone's like, all right, see you later, bye. And then the third is a wonderful video that NIDA put out. It's only about 4 or 5 minutes long. It's animated, it's cute. It really kind of illustrates what happens during an overdose and specifically how and why naloxone works. It's a great video just for us, but it can be a good resource for our clients as well. And then some more harm reduction resources. I did some Googling around. You guys, it looks like, have a wonderful resource, the Sonoran. I don't know if I'm pronouncing that right. Prevention Works. They seem like a good resource for naloxone. I also saw that they had fentanyl testing strips available through their website, and looks like they do a lot of cool advocacy. The National Harm Reduction Coalition, I highly recommend checking out their website. They are primarily focused on opioids. They do address some other substances, but it's primarily opioids. But it's so much information and so many ideas for advocacy and ways to get involved. Harm Reduction International, super cool website, especially if you're curious about what harm reduction looks like in other countries, because surprise, surprise, we are behind. If people need a resource to purchase fentanyl testing strips, they can do so safely and reliably from dancesafe.org. Again, a very cool website. It leans a little heavy on MDMA, so if you need information about that, it's a great source. And then for more information and safety about methamphetamine, I recommend tweaker.org. I will warn you, Tweaker is not everyone's cup of tea. It's a little graphic, but it's also specific and informative. So if you are looking for detailed information about methamphetamine and how it's used and all of that, I haven't found a better, more comprehensive source. In just a moment, we will switch gears and I will take questions. But if I don't get to your question today, or you would rather reach out to me directly, my email address is on there. You're welcome to use it. It's not an invitation. I will email you back. And also my website is on here. I try to keep my website pretty up to date. I have a lot of resources, a definitions page, a blog, and all of that. So I want to thank you so much for your time and your attention. I know that it can be tedious to listen to one person talk for over an hour. So you made it through, you're still here. Hopefully, I actually have no idea. I'm sitting in an office alone. Maybe there's no one there, but regardless, thank you. And thank you, Janelle, for the opportunity.
Thank you so much, Kim. That was amazing.
Thank you.
We do have some questions coming in. So real quick, I'm going to jump over to our question screen. Yeah, that was wonderful, Kim.
Thanks.
So the first question that we have, and I'm gonna throw it out there for you to answer, Kim, and then I'll also give a component from the Alliance perspective as well, because it is kind of asking about resources. So the question is, if we don't know the information to educate our patients about, where can we educate ourselves? Like, for example, why some of these things are important, accurate knowledge of risks, and knowing signs and symptoms.
So it's so hard to find all of the bits and pieces of information. I have spent loads of time, just if someone looks at my search history, they're going to be shocked. I'm not going to lie. In terms of just a general education on harm reduction, a fantastic book is Over the Influence by Pat Denning and Jenny Little. Tons of great information and really great kind of overview harm reduction for opioids, for stimulants, for psychedelics, all of that. Beyond that, really just starting to Google what you want to know and then looking for good, reliable sources of information. And when you find something, bookmark it. as a good starting point, I would recommend the National Harm Reduction and Harm Reduction International, and they sometimes link to other sites as well. And then anytime I find something that looks good that has a .edu or a .org, you know, I'll give that a little more time and attention as well. And I've just kind of compiled it, and I will let you go because you may have some more specific information for your area.
I appreciate that though, and I'm gonna put a link to that book in the chat just so you all have it. So all I was gonna say is that if you and your health center are feeling like you need further, more in-depth education around this, I want you to please reach out to me just so that we can see, regardless of where your health center is in the state, reach out to me through email to see what we can provide you with. We can most definitely provide your health center with overdose prevention, response, overdose prevention, recognition, response, all of that, additional detailed information around that. But I also have some resource lists for here in the state that I can send over to you as well. And one thing I did want to bring up as another resource is Never Use Alone, the website. So sharing that with your patients on the website, Never Use Alone, they have a phone number you can call. If you're ever going to use by yourself, you can call that number, and someone will sit on the phone with the person while they use without judgment or preaching to them. They will just ask for the person's information, where they are. And if they're not responsive after a certain amount of time, then they'll contact emergency services. So that's a really good resource that could save a lot of people. And we also recently had a meeting regarding fentanyl test strips. So I have some resources for any of the health centers that are interested, just around tips that are specific to fentanyl overdose. So we have some things that we're looking at printing off so that they can be given to patients. But also just so your staff can educate themselves on different tips that people can use if they are still using, like Kim talked about, using less, using slower, using a different method. There are so many that sometimes it's hard to remember them off the top of your head. So we do have some resources like graphics and stuff like that that I can share with you if you're interested in that. So yeah, just reach out to me, please, if you have any sort of needs around learning more. We also do have a training coming up in April. That's going to be another 1.5-hour training that is overdose recognition response. It's going to be open to everybody, a webinar like this, but it'll be more conversation based so everyone can turn their cameras on. And we have someone in recovery presenting that. So they have personal experience to share. So I definitely encourage you to check that webinar out as well. It's a really good, it's going to be a great complement to this one, so that we can just get more in depth about overdose prevention. Do we have any other questions? Please, if you do have other questions, don't be shy. Go ahead and type them into the Q&A. And something that I wanted to bring up, just because it's something I hear a lot from health center staff that I think they could benefit from, is you talked about enabling and codependency in your presentation. And so from the perspective of a clinician, I guess, what is your opinion between or what would you say to someone that's asking, is there a line for you as a therapist between harm reduction and enabling? Is there, how do you see that, I guess? Because I believe you put it really well.
Thank you. When it comes to our types of role, short of putting drugs in their hand, I don't really see it. And I think, and it's counterintuitive in some ways, and I get questions like this a lot. I had someone be like, you can't talk to people about drugs and alcohol like this. Like, they have to stop. Why do they have to stop? Right? When we look at things through the lens of what people are doing is bad and they're wrong and they have to stop, then through that lens, a lot of things can look like enabling, right? When we look through the lens of these are people who, regardless of what we say or do, is going to make their own choices. And how do we make those choices as safe as possible? And how do we create that environment in which someone is willing to use us for help? If somebody comes in to see us and they feel shamed or judged or not understood, regardless of where they are in that stage of change model, we may have kind of closed that opportunity. In substance use, so often you're not just helping the person now, because they may leave, they may not come back, they may not show up for that first appointment. But if they felt respected and cared for, you're building that bridge so that maybe they come back at a later time. And so I think, like I said, I think a lot of it is really the lens that we see it from. If you see it through the lens of this person, what they're doing is bad and they have to stop, then yes, a lot of things look like enabling.
I love that. And I think that perspective helps you a lot as an individual, a helping professional. I know that when I was doing direct care work, and when I started to think of it more as any positive change, that really helped me cope with things better, because I wasn't expecting things from people that they're not capable and maybe not ready or not wanting to do. When we do that, it hurts us, and it's can become overwhelming. So that mindset, I think, is better for everybody involved.
A compliment that I get from clients sometimes, and it always means a lot, is when they say, I've never been able to talk about my substance use like this before. They've just never been in a space where they can talk about it openly, in some ways positively, and not feel judged or pushed or backed into a corner or challenged, just validating a person's experience. And that is probably the area where I get some really positive feedback, and that it means a lot to me, because that's really my goal, right? Is just to be a person that is here to provide an atmosphere for support and change on their timetable, not mine.
Yeah, that's really great. And if they are ready, they'd probably come to you because they trust you, and they have built that foundation with you. So that's really awesome. And I think it's such an important perspective to have when helping people with this.
Yeah.
Is there anyone else that has any other questions for Kim? I'll give it another second before we go over evaluation. I did also want to bring up just how much I appreciate the way you provide examples, that are really relatable for people in this profession definitely helps to better grasp these things, and about how when you use the approach that Kim's talking about that she uses, it really helps people to start to care about themselves when maybe they didn't care about themselves or feel like they were worth very much. And so when you say, I care about you, your life matters, I want to make sure you're safe, that means a lot to the person. And eventually it may help them want to take better care of their health and take it into their own hands, because they're being reminded that people really do care about them. So it can really go a long way, even if it doesn't really seem like it. It really means a lot to people who are struggling. So thank you so much, Kim, for your presentation.
Thank
It
you
was
for the
really
opportunity.
wonderful. And the last few things I wanted to share with you all are, if you are requesting continuing medical education credit, then we'll have a link for you to capture your information. We'll have that link pasted in the chat. And then please fill out the evaluation form as well. It's going to open up once you're closing the window to the webinar. So please make sure you fill that out. And Kim, you're getting lots of thank yous and lots of compliments. If
I
you
was
can't
gonna
see
say,
them.
I saw some of the really kind feedback, so thank you, especially in this format, because I'm just here in Austin, Texas, all alone in an empty office. And so it's nice to know that there are people out there. And so thank you for y'all's kind feedback and your participation and reminding me that I'm not just alone.
And when you talk, I feel you answer any questions that would come up. You really do a great job with that.
Thank you.
So yeah, thank you so much. The content is just amazing. The last thing I wanted to mention is that our webinar for next month will be treating pregnant people with substance use disorder. So that'll be our focus for the March webinar, and we hope you'll all join us. And unless there are any last second questions here, we'll go ahead and wrap up. Thank you so much, Kim.
Thank you, Janelle, for the opportunity. I had a wonderful time. Thank you.
Thanks, everyone. Have a good day.